Solo, Sofra, anyone, Jim. Okay, dialysis. So why would you dialyze any patient? That's fine. Refractory as metabolic acidosis. That's fine.
Mhm. Okay. So indication for intubation will be for airway protection, laryngeal edema, a persistent low GCS, risk of aspiration if there's severe hypoxemia and severe metabolic acidosis, or maybe you want to transfer a patient from another institution to another. Then for dialysis, refractory hyperkalemia, metabolic acidosis, persistent fluid overload, anuria with rapidly worsening creatinine levels, uremic encephalopathy, and uremic pericarditis or neuropathy. So just in summary, in terms of this patient, she was with us for more than 6 weeks in labor ward. So if you look at her blood results, I just wanted to show you from admission and on discharge. So her HB was 8.1, her platelets were 308 on discharge, and also she had a potassium of 5.6, and her ura had normalized to ura of 4.8 and creatinine of 91. So this was after 2 sessions of dialysis, and so when she was in the ward, she developed steroid-induced diabetes, and she was started on metformin. Her acute kidney injury resolved after dialysis. So we were managing her as a TTP versus atypical HUS. She completed about 18 sessions of plasma exchange and received high dose of steroids. And then on discharge, her platelets were above 300. And she was discharged on steroid and antihypertensive and metformin 6 weeks later. So a week later, she came back for a readmission when she came in with a very severe DKA with a possible relapse of HUS and TTP because her platelets had dropped back to 11, and she subsequently demised on day 5 from the readmission. And then now I'll hand over to Dr. Maharaj, who's going to give us a brief approach in terms of these conditions, HUS and TTP.
Sorry, may I have a question just
Yes,
before? This is Dr. Mdlalose. Sorry, my question is, what are the rationale for using platelets on this patient? Because I think you said the platelets were transfused, and she was post-delivery. There was no surgery to be anticipated. So, what is the rationale to give platelets afterwards?
So initially, she got platelets for Caesar undercover, and then when she persistently had low platelets, then the hematologist said, let's give her another pool of platelets.
Yeah.
And she was for intubation,
Okay.
so they wanted platelets to be a bit higher.
So with that, when you're suspecting TTP, would that be a prudent idea, or what do you think? What do other registrars think? To give
I think you can
platelets
consult with your
if you are
hematologist.
suspecting TTP and HUS.
maybe that might not be a direct indication on its own, but taking the whole picture, you probably you are from inflation. My first question is, what was the trend on his chart? Who saw her? Who was
So she was with internal medicine on discharge. And they discharged her on metformin and steroids. They were planning to review her weekly because she had induced diabetes from the steroids. So when she on discharge, when she was discharged in April, she was supposed to come back a week later. And that's when she came in with the PKD. Sorry.
He beat us to the game.
Yes.
Doctor came back on day 6. I don't know.
Before,
Just
yes,
before
one
the-
second.
Yeah. Okay. Any other comments on the case? Otherwise, we'll move on to the case presentation, which will be mostly focusing on HUS TTP. And yeah, but the whole point of presenting this case was just to bring to everyone's attention that not everything that looks like a HELLP syndrome is a HELLP syndrome. And so when the picture doesn't make sense, because here you had a very high LDH, you also had very low platelets, but the LFTs were not so much affected. So when the picture doesn't make sense, and then you should always try and look somewhere else. And the patient was much more sick. If you look at most HELLP syndromes, they are usually just not as sick looking. It's patient you can talk to. Sometimes they are not even convinced that they should be delivered because they don't feel like they are sick, or whatever you're saying to them usually that just doesn't make sense. But when the patient is much more sick than the most patients you've seen with HELLP syndrome, and then you should be looking somewhere else. Okay, thanks, Dr. Maharaj.
Good morning, everyone. So, thrombotic microangiopathies are a group of diseases characterized by the presence of microangiopathic hemolytic anemia, thrombocytopenia, microvascular thrombosis, which is also followed by organ damage of varying severity. It can be genetic or acquired, or acute or progressive. Prompt recognition and the initiation of early and specific therapies substantially reduces mortality. So pregnancy-related TMAs, which are generally a secondary form, are rare. It has an incidence of 1 out of 25,000 births, accounting for 8 to 18% of all causes of thrombotic microangiopathies. The physiology of pregnancy can promote the onset or recurrence of TMAs, particularly in the second and third trimester. So although TMAs may show different etiopathogenesis routes, they all show the presence of a pathologic lesion, which is characterized by the endothelial damage and the formation of thrombi rich in platelets at the microvascular level as a common denominator. The thrombotic damage to the microcirculation pathways induces mechanical hemolytic anemia, the consumption of platelets, and the ischemic organ damage, all of which particularly affects the central nervous system and the kidney. In pregnancy itself, the two mechanisms is a progressive increase in the Valvullobrand factor during gestation, and an increase and accumulation of the ultra-larger multimers or reduction of the A disintegrin metalloprotease with thrombosporin type 1 domain 13 activity. These mechanisms are unable to counteract the possible presence of inhibitory antibodies, and the most common causes of microangiopathy with target organ damage in pregnancy is usually preeclampsia or eclampsia with HELLP. The rarer forms of pregnancy-associated thrombotic microangiopathies are hemolytic uremic syndrome and thrombotic thrombocytopenia purpura. It's not changing again. Prof, I need my presenter.
Just present what is here.
Oh, you need to read the notes.
Yes. The notes that are there.
Just exit this thing. You just present what is showing.
Gestational or incidental thrombocytopenia, giving us an incidence of 75 to 80%. followed by preeclampsia being 15 to 20% and ITP 3 to 4%. And there is rare occurrences of all three, TTP, HUS, and acute fatty liver in pregnancy. This diagram depicts the causes of thrombocytopenia in pregnancy according to trimesters. So in trimester 1, the most common one is noted is ITP, and it is evident that there is incidence of TTP and HUS, but it's very rare. Trimester 2 diagram illustrates that depending on the platelet count, the most common causes include gestational thrombocytopenia, followed by preeclampsia. There is a noted increase in the incidence of TTP and HUS in comparison to trimester 1. And the thrombocytopenia causes in third trimester are largely due to gestational thrombocytopenia and preeclampsia, though the incidence of TTP and HUS is higher in this period. Here are the differential diagnosis of microangiopathic hemolytic anemia and thrombocytopenia, which again include TTP and HUS, DIC, sepsis, disseminated malignancy, preeclampsia or eclampsia, systemic vasculitis, and malignant hypertension itself. So the typical symptoms of HELLP syndrome are epigastric pain and right upper quadrant tenderness, nausea and vomiting with headaches and visual disturbances. The symptoms tend to be more severe in the nocturnal hours after hospitalization that occurred in the daytime hours. So laboratory diagnostic criteria for HELLP syndrome is summarized as above, where we have peripheral smear abnormalities, excuse me, usually abnormal erythrocytes, which confirms hemolysis. Increased reticulocytes, which also confirms the release of immature erythrocytes. An increase in LDH and low HB, which indicates destruction of the erythrocytes. And the AST and ALT increases are linked with liver damage resulting from the microangiopathic hemolytic syndrome itself. Thrombocytopenia is due to platelet activation and its relative adhesion to the damaged endothelium. And we could use heptoglobin, which low levels would indicate hemolysis. It can be used as a hemolysis marker itself. Okay. TTP and HUS. So thrombotic thrombocytopenic purpura is a autoimmune or congenital. It is characterized by microangiopathic anemia and thrombocytopenia with variable organ ischemia, like mentioned, neurologic, cardiac, or renal. And rarely congenital TTP arises from the mutation of the disintegrin metalloprotease with thrombosporin type 1 domain 13 gene, where there's a mutation there. And usually when there is a deficiency, this presents of 100% of the TTP risk during pregnancy itself. So TTP is caused by acquisition of inhibitory autoantibodies against the disintegrin metalloprotease with thrombosporin type 1 domain 13. And adult onset constitutive TTP can be encountered for the first time during pregnancy. So during pregnancy, it's very important to be able to differentiate between preeclampsia and HELLP, as appropriate treatment is critical for the reduction of maternal and fetal morbidity and mortality rates itself. In pregnant patients with immune-mediated TTP, an acute phase should be managed with plasma exchange and corticosteroids if tolerated. Hemolytic uremic syndrome is a rare disorder. About 10 to 12% of atypical hemolytic uremic syndrome occur in the setting of pregnancy, frequently in the third trimester or postpartum period, where it's termed pregnancy-associated atypical hemolytic uremic syndrome. Usually it arises in context of obstetric complications like preeclampsia, abruptio, IUD, or PPH, and is characterized again by microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. It occurs due to uncontrolled complement activation, and mutations in regulating the complement system itself is seen in about 60% of the cases. So pregnancy-associated atypical hemolytic uremic syndrome can be considered in patients with the microangiopathic hemolytic anemia and thrombocytopenia if the patient is generally less than 20 weeks, more than 48 to 72 hours postpartum, and has a positive family history of HUS itself. The differentiation between HELLP and HUS is crucial for treatment. With regards to the etiologies and the association to TTP and HUS, it can be idiopathic, familial, can be due to an infection or autoimmune disorders. It could be pregnancy and postpartum, could be found diagnosed in the pregnancy and postpartum period, could be due to a malignancy, and can occur due to certain drug uses of therapy such as chemotherapy or bone marrow transplantation. So both TTP and HUS have been hypothesized to be a result of platelet aggregating agents in circulation and with endothelial cell injury. Widespread formation of platelet microthrombi results in consumptive thrombocytopenia, end-organ ischemia, and intravascular hemolysis due to the fragmentation of red blood cells as they traverse partially occluded arterioles and capillaries. So the thrombi itself consists primarily of von Willebrand factor and platelets with minimal fibrinogen or fibrin and no inflammation. An inhibitory antibody to the von Willebrand factor cleaving protease has been detected in patients with acute idiopathic TTP, but not in familial TTP. So endothelial cell injury may result in a widespread of unusual large von Willebrand factor forms. Clinical manifestations between TTP and HUS, they both have a microangiopathic hemolytic anemia, thrombocytopenia, renal insufficiency or acute kidney injury, neurological manifestations seen in TTP, fever in TTP, and GI symptoms in HUS. All suggest platelet microaggregate formation, and with sepsis or DIC, you'd see sepsis with, rigors would be present with the fever. This is just to summarize the previous slides on the pathogenesis and the clinical factors of both TTP and HUS that we've gone through already. So with regards to time, we're just going to pass that. So characteristic laboratory abnormalities in patients with TTP and HUS, excuse me. So you have your microangiopathic hemolytic anemia, where you'll see fragmented red blood cells or schistocytes on the peripheral smear, reticulocytosis, increased indirect bilirubin levels, decreased haptoglobins, negative direct Coombs testing. With the thrombocytopenia, the platelet counts are often as low as 20. With the coagulation studies, there's normal APTT and PT with a negative DIC screen. There is markedly increased LDH level usually, and there is a variable increase in creatinine level, being HUS more than the TTP. So TTP is not a primary disorder of coagulation or thrombin activation, and coagulation studies are usually normal. Here's a good table that basically summarizes the comparisons between the laboratory abnormalities amongst TTP and HUS and HELP itself. So the following can be noted. HUS shows a higher platelet count than the other two differentials. Reduced HB is significant in HELP syndrome. The peripheral smear can have severe schistocytes or the absence of them in HELP syndrome. Schistocytes are present in both TTP and HUS. The LDH level is usually elevated or more significant in TTP. The creatinine levels are mostly elevated in HUS compared to the other two differentials. The transaminase levels are significantly elevated in HELP syndrome, and the coagulation screen is noted to be significant in HELP. Other laboratory features are the A disintegrin metalloprotease with thrombosporin type 1 domain 13, which was significant in both HUS and TTP. And to differentiate between the two, we look at the value. If it's less than equal to 10%, it's more likely to be TTP, and more than 10% makes it more likely to be HUS. So reflecting back on our case, we noted the LDH of 3,000 and the low platelets, though AST-ALT was borderline, indicating that it was not diagnostic of HELP. So when it comes to clinical scenario and differentials, if there is complications after delivery, or if there's persistent abnormality, or if it's prolonged for more than 2 days, we should consider HUS. With hemolysis and renal dysfunction, which worsens or is persistent after delivery for no reason, with no reason, so HUS should be considered as well. Just to touch briefly on acute fatty liver of pregnancy, it is a rare pregnancy condition that persists with the thrombotic microangiopathic features, usually not associated with hypertension or proteinuria, but does have metabolic acidosis, acute liver failure, and low-grade DIC. So laboratory abnormalities that can be seen is hypoglycemia, elevated serum bilirubin, elevated AST and ALT, elevated ammonia and white cell count with low platelets and coagulopathy. It's important to note the Swansea criteria for acute fatty liver pregnancy, which should be considered if the patient is positive for at least 6 out of the following 15 criteria, which is vomiting, elevated uric acid, abdominal pain, polydipsia or polyuria, encephalopathy, increased bilirubin levels, hypoglycemia, coagulopathy, acute kidney injury or creatinine levels that are elevated, a bright liver on ultrasound, increased ammonia levels, increased ALT levels, ascites, increased blood cell count, and microvascular stasis on liver biopsy itself. So here we're comparing TTP, HUS, and acute fatty liver pregnancy. So platelet count is usually more than 50 in acute fatty liver of pregnancy. HDL, the LDH is also significantly, sorry, peripheral smear. Post-call Dr.
But you're right, that's me as well.
Goodness. The LDH is also significantly raised in acute fatty liver pregnancy. The creatinine levels are still more elevated than in HUS. Creatinine levels is still more elevated in HUS compared to the other two differentials. The liver enzymes are most elevated in acute fatty liver pregnancy. So other lab significant of acute fatty liver disease in pregnancy is elevated ammonia and low blood glucose levels itself. With regards to the management, there's plasma exchange therapy and ancillary therapy that includes corticosteroids, antiplatelet agents, and supportive care. So with plasma exchange, it's the most important component of therapy, which is indicated for all patients with suspected TTP and HUS. So patients who are ineligible because of renal failure or patients who we have concern for volume overload with plasma infusions, as well, will show. So plasma infusions provide replacement for missing or inhibited vulnerable factor cleaving protease. And when used with plasma exchange, it actually simultaneously removes pathogenic autoantibody of the factor itself. So if plasma exchange is not available, FFP can be used until it is arranged, but it's not an acceptable alternative to plasma exchange itself. Schedule and duration. So plasma exchange replacing one calculated plasma volume daily with either FFP or supernatant plasma should be initiated as soon as diagnosis is suspected. Plasma, which is a plasma that remains after cryoprecipitate is prepared, which is depleted of the von Willebrand factor, has theoretical advantage. It's used initially or in cases of refractory disease. So initially, we give this plasma exchange therapy daily with daily evaluations of the biochemical parameters. And the duration of therapy is variable until we achieve remission itself. So remission itself, once it is achieved, the plasma exchange therapy cannot be tapered and ultimately discontinued. Reinstitution is a reality as certain patients respond to tapering with a rapid decline in platelets and increase in LDH again. So the major risk related to the two plasma exchange therapy itself is central venous catheter insertion alone. The glucocorticosteroids can be used variably based on historical data of possible efficacy in the era before plasma exchange and reports a resolution of less severe cases with high doses of prednisone alone. So antiplatelets, as the glucocorticoids, the efficacy of plasma exchange therapy has made it difficult to assess the additional benefits of antiplatelet agents. The aspirin may have a role once platelet count increases with plasma exchange therapy. With platelet transfusion, generally contraindication indicated with patients with TTP unless there is major hemorrhage or an invasive procedure is required. Supportive care includes red blood cell transfusion, medical interventions for hypertension control, hemodialysis, and anticonvulsant therapies. So counseling and strategy for future pregnancies may differ based on the diagnosis of acquired TTP itself. The general population, acquired TTP reoccurs in 15% within weeks after clinical remission and 30 to 40% in over subsequent months and years. So with the disintegrin metalloprotease with thrombosporin type 1 domain 13 monitoring, less than when you have a value of less than 10%, there is a risk of relapse and prompt close surveillance is advised. Pregnancy after an episode of acquired TTP has a 10% reoccurrence, and the disintegrin metalloprotease with thrombosporin type 1 domain 13 activity and antibody should be sent prior to and in the first trimester itself. Pregnancy and congenital TTP, there's a more than 50% chance of relapse in patients who didn't receive therapy during pregnancy itself. So when it is actually confirmed, prophylactic plasma infusions and it should be administered and advised to prevent relapse itself. In conclusion, the borders between the different forms and presentations of thrombotic microangiopathies are not well defined. So differential diagnosis may be difficult or even impossible because of these conditions that coexist. To further complicate the diagnosis process during pregnancy, the hematological and proteinuria and complement parameters have different reference ranges than in non-pregnant patients. The differential diagnosis between these diseases require careful clinical evaluation and especially an assessment of laboratory parameters. TTP and atypical HUS associated with pregnancy or postpartum period require urgent management, biological testing, and specific treatment. And although TTP or HUS are rare symptoms, early diagnosis and early intervention with a multidisciplinary team approach assist in decreasing morbidity and mortality rates significantly. Thank you.
Thank you, Dr. Maharaj. I think we have run out of time, but we can take a comment or two, and then we'll close the meeting. Dr. Moran.
Firstly, thanks for the presentation. And just looking back at the case, obviously it's a sad case because after all this input and effort, she eventually died. So my understanding is that we didn't have much treatment for this condition. Those who tried, the prognosis was not that good anyway. Now, the plasma exchange seems to be the primary modality of treatment. And from what you were saying, it's not clear whether, when you're doing the plasma exchange, whether also giving steroids actually improves the outcome or not. Is that right?
Yes.
So I'm just wondering whether maybe next time we should just do the plasma exchange. That's available. Because in this case, she complicates with the steroids as well. If the evidence is not clear on adding steroids to actually help them, then maybe that would be something to discuss.
Yeah, I think that's a good point, Dr. Moran. But yeah, the patient was being managed in consultation with hematology. So I don't know how we feed back to them, but maybe they noted that as well, that maybe they can do something different next time. Any other comments, questions? Anyone online? Okay. No, that's 12 chats in London. So
cases where you manage like this for weeks with plasma exchange, is this something that you see now and again, or is this quite an unusual case?
Very unusual. We haven't seen this for a very, very long time from what I can remember. When I saw this patient, she really bamboozled her initially because she just obviously after delivery started deteriorating rapidly. I remember I was on check, I don't know whether Friday and Saturday, but Monday when I saw her, she was now down. I initially when I saw her, I wrote her off, on Mondays, she'd never be making until the younger consultants came and said, "Oh, on this stage, the younger consultant came and said, "Oh, you need a plasma exchange." I said, from my experience in the past, I never did well, but obviously at those days we didn't have that state, it was very limited. And I was obviously pleasantly surprised when she recovered. So no, we haven't seen it for a very, very long. The TPP with this severity. But fortunately, I think initially the differential was there. We didn't take the differential when we were looking at it. And on some of these tables that Barak is supposed to present, I said, go and find that table with the 3, with the 4 kind of things. And when I came back, we found the table. Yes, we found the table. Here it is. When I came back in the evening, when I was doing this, yeah, now we haven't seen it.
Yeah. Yeah, those tables saved the life. Initially, but not for a long time. Okay, thank you, everyone. I think that's the end of the meeting.
Yeah. On the